my talk is probably the most uninteresting talk for you all, so you're just going to have to wade through me to the next talks. I'm going to talk about the unmet needs and device therapies in HFrEF, okay? And I think these are, again, my consulting. So I think everyone recognizes that the clinical course of heart failure is progressive. You recover from heart failure episode, you never really get back to the exact level you were started off at, and it's a gradual decline. We start optimal guideline-directed medical therapy. You have this window where patients actually may benefit from device therapy, but as the progression occurs, you eventually land up in the arena of advanced therapies, and you try to avoid that, and that's one of the main reasons to avoid that. One of the ways to avoid that is to ensure that patients are maximally on their maximal guideline-directed medical therapy. And the reason for that is because it actually adds almost 1.4 to 6.3 years of your life if you're on a combination of an RNA beta blocker, an MRA, and an SGLT2 inhibitor. So it's really important that drugs essentially be maximized. But the important thing to recognize is that even though drugs land up enhancing long-term outcomes, they don't really enhance your physical activity. They don't enhance your effort tolerance. And as opposed to that, when you look at device therapy like CRT, you can see that the physical activity after getting implementation through a device is actually markedly more. Now, CRT is a great therapy, but it's only indicated for a small component of that larger cohort, right? So if you have 6 million patients with heart failure, only 30% of those patients, I mean, half of them, of the 6 million, are HFrEF and the other half are HFpEF, but within HFrEF, the only 30% of those patients actually are eligible through Class 1 and Class 2A indications for resynchronization therapy. So if you look at how therapy has evolved over the years, in 1985, we had our first ICD discovery. It was only later in 1996 that ICDs became acceptable for primary prevention. And then later on in 2002, CRT devices were approved by FDA. And then we had a long hiatus. We had multiple studies that were done. These were multiple studies, the narrow QRS studies that were done, the Rethink study and the ECHO CRT study. They were all duds. Subsequently, there were other implantable studies which looked at neuromodulation. They included spinal cord stimulation. At the same time, they used vagal nerve stimulation. And again, the results were fairly neutral to negative, and you must have heard of the recent Anthem HFrEF study, right? Which was an 800-patient study, but was stopped at 500 because they found it to be futile to continue with the study because there were really no significant differences seen out there. This brings us to Baroreflex Activation Therapy. This is a therapy that involves stimulation of the carotid baroreceptors, and you'll hear from my colleagues how they actually do it or get it done. This actually then translates into, hopefully, clinical benefit, and we'll talk about it. So we know that with heart failure, there is a reduction in baroreflex sensitivity. And just for a quick reminder about baroreflex sensitivity, when you look at heart rate, blood pressure changes, the arc between the heart rate and the blood pressure change is the baroreflex sensitivity. The lower the BRS, the worse it is for patients. Along with that, in heart failure patients, you have a higher sympathetic tone and a lower parasympathetic tone. We know that doesn't work very well. And in conjunction with that, patients have symptoms. So how does Baroreflex Activation Therapy actually work in these particular situations? And you can see on the next slide that Barostim actually increases baroreflex sensitivity, and baroreflex sensitivity, as you know, is directly linked to outcomes and prognosis and mortality. And the better the BRS you have, the better patients do. So clearly it improves the baroreflex sensitivity. Now, another way of measuring sympathetic activity is muscle sympathetic nerve activity. And you have neurologists who do that, especially those who look at small fiber neuropathy. They also look at some sympathetic nerve activity. And there is a decrease in sympathetic activity, an increase in sympathetic activity, as you can see, in patients with heart failure. Now, with Barostim also, it increases the parasympathetic activity, and this parasympathetic activity is protective. As we all have heard, this terminology called sympathovagal balance. You need to have the appropriate sympathovagal balance, that is a reduction in sympathetic activity and an upregulation of the parasympathetic activity. And you can see out here, with Barostim turned on and off, there is a reduction there's an increase in sympathetic activity and an improvement in the high frequency level, which is parasympathetic activity. Everybody knows LF and HF. LF is reflective of sympathetic. HF is reflective of parasympathetic activity. So clearly now we have evidence that carotid baroreceptor stimulation translates into an improved baroreflex sensitivity, improves the sympathovagal balance, but the question is, does it have an impact on heart failure symptoms? So to answer that, we have the BEAT-HF study, which many of you have heard of. I think there were about 264 patients, the BEAT-HF study initially, and then the subsequent entire cohort is about 329. But just to bring you up to speed out here, there's an improvement in exercise capacity with the turning on of Baroreflex activation, as you can see out here. And this, I want you to compare this with the CRT results out here. I'll show you a graph at the end that really contrasts and shows how well actually activity is enhanced. And you can also see that there's an improvement in quality of life with BRS, which is again comparable, if you can see out here, with that observed in CRT trials. And then last but not the least, you have an improvement in NYHA class. So clearly, Baroreflex activation therapy improves clinical symptoms out here too. I'm going to move on to the next slide if this lets me do it. And then what about harder outcomes? That becomes the question. Does it actually impact serious cardiovascular events? And if you look at the BEAT-HF study, they looked at different endpoints out here: cardiac arrhythmias, MI, angina, hypotension, syncope, and a total endpoints in patients that received Barostim versus that had controls. And you can see that there was a significant reduction, almost a 51% reduction in the overall cardiovascular events in patients that got Barostim and had Baroreflex activation therapy turned on. Having said that, I think we now know that clearly it works on all fronts that we talked about, improving heart failure symptoms. And this is the slide you can see right at the end out here. It actually improves physical activity and effort tolerance, almost comparable to CRT in a handful of patients that have been actually displayed out here. And that really is something that is really striking out here. You can see that come up out there. So the BEAT-HF study is the post-market study, as you know. This was a study looking at the entire cohort, followed up for a period of almost 3.6 median years, okay? And when you look at the outcome, the primary endpoint of the BEAT-HF study found that those patients actually did not respond by the primary endpoint. There was no difference in the primary endpoint of a composite of cardiovascular mortality as well as HF morbidity. But when you look at the subsequent analysis, which was a pre-specified additional analyses, looking at all-cause mortality, you can see that it's almost teetering over clinical significance. But when you look at the hierarchical win ratio, and the hierarchical win ratio out here includes cardiovascular mortality, HF morbidity, and quality of life, you can see that it actually favors Baroreflex activation therapy as compared to the control. So clearly shows a statistically significant difference out here. And then obviously when you look at all the clinical parameters, whether it's freedom from MANS-related events, MANS being major adverse neurological and cardiovascular events, as well as quality of life and exercise capacity and functional status, you can see pretty clearly that all of those turn out to be winners in the BAT arm compared to the control arm. So with that, I think the conclusion basically out here is that there's a totality of evidence that indicates that BAT is safe, it's effective, and it's a durable treatment for patients with heart failure and a reduced ejection fraction. And this brings me to my last slide. And now you have basically, you can see the progressive devices since 1985, and now in 2019, we actually have 2 therapies that could potentially be used in the HFrEF patient population with a narrow QRS, and that could be either the Impulse Dynamics device or the Barostim device. And all my colleagues out here have experience in both these device therapies, and it'll be really interesting to hear their talks as to what their impressions are. And with that, I want to thank you for your kind attention.